Medurstand. Understanding medicine.
I am Professor Aziz-ur-Rehman, and today we are going to talk about this very strong connection between diabetes and heart. And we will actually examine the role of Nebivolol. Nebivolol is a novel beta blocker and it offers some unique benefits which can be used in preventing diabetic complications, cardiovascular complication in diabetes. So let's examine this. The connection between diabetes and heart disease is so strong that it is aptly described as cardiobetes. That means it is the disease of heart. Having diabetes is as if you already have heart problem because there's extremely strong relationship between the two. Now, diabetes is primarily diagnosed on the basis of glucose or a surrogate marker of glucose, which is hemoglobin A1C. I'm not going to go into the details, but this slide describes the pathogenesis of hyperglycemia. Not just beta cell deficiency, but alpha cell excess, then disposal of glucose in the muscle is reduced, and there is abnormal production of glucose by the liver in fed state also, the release of fatty acid and certain toxic substances from the visceral fat, then deficiency of incretin, and then homeostasis, where the regulation from the brain is abnormal, all leads to hyperglycemia. Hyperglycemia is one major component of diabetes, but it is just one component. I would say it is the tip of iceberg. There is a whole long list of associated conditions. And unless we address those associated conditions, we cannot prevent cardiovascular complication of diabetes. Many studies have shown very good benefit of A1C lowering on microvascular complication, but when it comes to macrovascular complication, particularly cardiovascular disease, then the effect is much less because of these associated conditions. Now, diabetic complications, metabolic complications are literally now preventable, and if they occur, they are completely treatable. Then we have microvascular complication. That means nephropathy, retinopathy, and neuropathy. They're also mostly preventable, and there's a very good effect of good glucose control on microvascular complications. But major I think complication is cardiovascular. About 80% of the diabetes related morbidity and mortality is cardiovascular. So I think we're going to examine this one. So this is a very interesting picture, and you can see there are multiple mechanisms. We could spend half an hour on this slide alone, but I'm going to be relatively brief. These are 7 components, and one of them hyperglycemia, and 6 more components which actually contribute to atherosclerosis and other vascular disease. So in the center we have blood vessels with atheroma and clot formation, and let's examine how these factors they contribute. Let's first take insulin resistance. Insulin resistance is believed to be the first part, the initial part of diabetes, and that is when there is hyperinsulinemia, but that is enough to correct your hyperglycemia. So there is insulin resistance, and that is compensated by hyperinsulinemia. That may be sufficient to control your glucose, especially in the fasting state. Only after glucose loading there may be hyperglycemia, but this hyperinsulinemia itself is believed to have some adverse effect on the vessels, because insulin is a growth promoting factor and it could actually promote the growth of atheroma. So once this compensating mechanism fails, that leads to deficiency of insulin, and because of beta cells are exhausted and alpha cells are in excess, so there is insulin deficiency, and that is actually responsible for many other complications. So hyperinsulinemia and insulin deficiency. And these two results in hyperglycemia. Now this is the third component, advanced glycated end products. When there is prolonged hyperglycemia, this leads to glycation of many tissue proteins. We are very familiar with glycated hemoglobin because that we use for the diagnosis and monitoring purposes. But all tissue proteins, including LDL proteins, lipoproteins, they can get glycated. Once a protein is glycated, its chemical properties are not changed, but its physical properties are changed. So because of glycation of proteins, it ultimately becomes advanced glycated end products. So I think maybe the proteins in the intima and the proteins in the cell wall and also the proteins circulating like lipoproteins, they get glycated. Then we all are familiar with characteristic dyslipidemia. So how has this happened? The visceral fat, which is almost always there in abundance in type 2 diabetic patient, this visceral fat produces certain cytokines like TNF-alpha. This is tumor necrosis factor. This is a pro-inflammatory or an inflammatory marker. So this would produce inflammation, and inflammation is very, very important in the pathogenesis of atherosclerosis, particularly in the final stage of atheroma rupture and clot formation. So this TNF-alpha coming from the visceral fat, that is important. Plus this visceral fat produces free fatty acids, and these free fatty acids are brought to the liver and they are converted into triglyceride and also special lipoproteins, LDL particles, which are small and dense and very, very atherogenic. That also results in reduction of HDL. So this HDL, is a friendly lipoprotein. So this combination of increased free fatty acid, increased triglycerides, increased VLDL and reduced HDL and atherogenic small particles of LDL, they all contribute to accelerated atherosclerosis. Then thrombotic and fibrinolytic factors. In patients with diabetes, liver produces increased CRP. CRP is an inflammatory marker, and it produces more fibrinogen, and it also produces more plasminogen activator inhibitor. So all these, they cause thrombosis and at least pro-thrombotic state. So hyperlipidemic, hyperglycemic, pro-inflammatory and pro-thrombotic state all lead to thrombosis formation. Now finally, hypertension, very, very common in patients with diabetes because the diabetes can cause hypertension. Hypertension can also cause diabetes. Both may have common factors, common phenotype. So hypertension is extremely common in type 2 diabetic patient, and that also contributes to the atherosclerosis. So I think these factors, but we must understand one thing: all patients having the same degree of these factors are not equally prone to develop cardiovascular disease. So there are some factors which are still not known. We attribute them to genetic factors. So there are still some hidden, probably genetic factors which contribute to pathogenesis of macrovascular complication. So when we treat diabetes, we have to consider all these factors. Because of these factors, on the average, patient with type 2 diabetes, they are, I think, at odd at all levels. For example, they are 3 times more likely to develop ischemic heart disease or cerebrovascular disease because of atherosclerosis, and then they're 3 times more likely to develop an acute coronary event, and then they are 3 times more likely to be unsuitable for revascularization or angioplasty. So diabetes patients are at odd at all levels. This is the graph which shows that although I told you other factors are important, but glycemia is definitely important. You can see the incidence of cardiovascular disease is proportional to the degree of this glucose level. As your HbA1c rises, the chances of atherosclerotic cardiovascular disease also increase. So I think glucose remains important. This is UKPDS data. Very important, this is time, and at a certain time when somebody's HbA1c touches 6.5 or exceeds 6.5, that is a time when a formal diagnosis of diabetes is made. Microvascular complications typically start developing after the diagnosis. In fact, this 6.5 A1C correspond to that level where the incidence of microvascular complication suddenly increase. But you see this one, macrovascular complication, they start developing much before the diagnosis of diabetes is made, maybe up to 10 years before diagnosis of diabetes is made, and this is because of certain unknown factors and maybe because of the abnormalities which actually cause hyperglycemia. They themselves are responsible for increased cardiovascular disease. So I think we have to act early, and we have to act really very early, maybe before actually the diagnosis is made, at the level of pre-diabetes, and also maybe a condition which is before pre-diabetes. Somebody is just prone to develop, predisposed to develop these complications. This is very interesting, two studies actually, and I'm going to highlight these two areas. Now these two bars, this one compared to this one, are almost equal. These two bars are also equal. Okay, so that means if somebody has suffered from myocardial infarction previously, so chances of developing an acute coronary event in that person is the same as in a person who has just been diagnosed a case of diabetes. Similarly here, so that means diabetes is coronary artery disease risk equivalent. Actually, the philosophy behind this concept is that somebody who already has coronary artery disease, he has maximum chances of developing another event. So having diabetes is actually equal to having coronary artery disease. Although now we realize that this is slightly an overstatement, but people with diabetes of like 5 to 10 years duration, they are equivalent to coronary artery disease risk. So very, very important. Once somebody has a coronary event, his life usually changes completely. I think that kind of attitude is needed. Once the diagnosis of diabetes is made, the lifestyle changes are required so that we can prevent an acute coronary event. So this would lead to this very important concept of A, B, C, D of type 2 diabetes. So if you really want to prevent atherosclerotic cardiovascular disease in type 2 diabetes, you have to act on this A, B, C, D. Now A is for HbA1c. So that means you should do whatever you can. Lifestyle changes, weight management, oral medication, injectable therapy, and you should ask your patient to do whatever is possible to bring down your A1c to minimum 7, but ideally in young patients to 6.5 or even less. Those who are aged and already have cardiovascular disease, because of the risk of hypoglycemia, we can accept 8 or something around 8 also. The second is blood pressure. Now all societies of the world, they say that blood pressure must be controlled, and the goal is 130 by 80. In diabetic patient, goal should be to bring the blood pressure down to 130 by 80, not 140 by 90. And preferred agent is a RAS blocker, either angiotensin converting enzyme inhibitor or angiotensin receptor blocker. This is as per European Society of Cardiology and European Association for Study of Diabetes. Although JNC 8 says that you could use any agent and all you have to do is to bring it down to 140 by 90. But I think most societies, I personally myself would like to bring it to like 130/80, and I would prefer to use RAS blocker. Now, when it comes to cholesterol, we need to bring down LDL cholesterol to 100 or less, or if somebody has ischemic heart disease, then 70 or less, right? Or 50% of the baseline. And then finally, Disprin, which is actually aspirin. I've used this Disprin just to make this ABCD concept. This is actually aspirin, any brand of aspirin. It may not be helpful as a primary prevention and all, but if somebody has got two risk factors, one is diabetes, one more risk factors, like one or two more risk factors, like visceral obesity, hypertension, I think then usage of aspirin is also helpful. Now, many would argue that all diabetic patients, in addition to glucose lowering therapy, should receive ACE inhibitors or ARB, a statin and aspirin. I think I would leave it to you if you want to do that, but many people argue that that is actually a practical approach because this therapy actually helps. Certainly in those who have raised blood pressure, certainly in those who have elevated cholesterol, and certainly those who have two additional risk factors, we must use these agents. Now, this is the main focus. How do we control blood pressure in patients with diabetes? And we're going to examine this part in more detail. Now, recommendations are that we should try to achieve less than 130/80 sitting blood pressure with RAS blocker. But if beta blockers are currently not included in the first tier of recommendation, but everybody agrees that beta blockers can be used for their compelling indications. The compelling indications are ischemic heart disease and heart failure, and maybe some cases of migraine and anxiety. So if those conditions are present, then maybe beta blocker can be used. Beta blockers are great medicine. So beta blockers, they have a brighter side and a darker side in general. So I'm going to examine first the brighter side. Modest blood pressure lowering effect, cardioprotective, particularly in post-MI phase. Anti-ischemic because they reduce cardiac output, and we use it in angina and we use it in ischemic heart disease. Survival benefit in heart failure. And these diuretics, ACE inhibitors and ARBs are very useful in symptomatic control of heart failure, but they do not necessarily prolong life. Beta blockers are proven therapies which actually prolong life in patients with heart failure. Then their antiarrhythmic properties and their effect on palpitation. So this is the bright side, but there is a darker side also. The darker side means the people with beta blocker, particularly non-selective beta blockers, they tend to develop this lethargy and they may develop bronchospasm, particularly those who are already prone. They may develop erectile dysfunction, they may develop cold extremities and dysglycemia. So this is the darker side. Traditional beta blocker, despite these benefits, they have limited application because of these adverse actions. So I think if there is a beta blocker which has this brighter side only, but not the darker side, I think that should be welcome. So Nebivolol is one such beta blocker. It belongs to the group of beta blockers, but it has got some additional pharmacological qualities. That is why it stands out as unique beta blocker. Now, what are those? It has got beta as well as alpha blocking effect, and this is in the group of vasodilating beta blockers. We have 2 or 3 vasodilating beta blockers. Like we have one is Nebivolol, then we have CARVEDILOL, we also have labetalol. So these are beta as well as alpha blocking effect. But beta effect in Nebivolol is selective. It is B1 only, beta 1, not beta 2. And then it has got unique nitric oxide enhancing effect through its agonist activity on beta 3. So this is the the development of beta blockers. Initially non-selective beta 1 and beta 2 beta blockers were developed, and classical example is propranolol, another one is nedolol. Then we developed cardioselective because of the side effect, and the scientists they came up with beta blocker which would have effect only on beta 1. So they would cause cardiac benefit but not produce side effects related to beta 2. So the groups include metoprolol and bisoprolol. Then came in the era of non-selective but beta 1, beta 2 and alpha. So there is alpha blocker also. These are dual blockers, beta blocker as well as alpha blockers, and one example is carvedilol. And then finally this nebivolol, which is combined beta 1 and alpha blocker, but it has got additional agonist activity on beta 3, and that is responsible for nitric oxide production. So this is different than carvedilol for two reasons. One, it has got beta 1 selectivity, and number two, it has got this beta 3 agonist activity, and this is unique beta blocker nebivolol, which is focus of our discussion today. Nebivolol is a racemic form. There are two forms. One is D-nebivolol and the other is L-nebivolol. And you have just nebivolol, but inside it there are two racemic forms, D and L form. They have different action, and they have action on the heart and they have action on the blood vessels. Let's first examine the action on heart. Action on heart through beta 1 antagonism is reduction in heart rate and increased cardiac output, increased stroke volume, and improvement in diastolic function and reduction in peripheral vascular resistance. And the effect through beta 3 agonist activity reduce oxidative stress and increased bioavailability of nitric oxide. And this increased bioavailability of nitric oxide translates into reduction in apoptosis and also improvement in ischemic protection of the myocytes and also improvement in cardiac contractility. Then we have L-nebivolol that primarily works on the blood vessels, and through beta 3 agonist activity it again reduces oxidative stress and it increases nitric oxide bioavailability, reduces peripheral vascular resistance and increases cardiac output. So these are the advantages. You can well appreciate that this beta blocker has got unique features unlike many other beta blockers. So beta 3 agonist action, little more detail. This is L-arginine, which is an amino acid which is present in our body, that is converted into nitric oxide, and then as a second step it is converted into nitrous oxide, and this is done by an enzyme called endothelial nitric oxide synthetase. Now this is function of endothelial cell. Endothelial cell is now considered to be an organ. It produces many healthy substances, and one of them is this nitrous oxide. And this nitric oxide has got many functions. It causes vasodilatation. The entire vasculature is has lined with the endothelium. So wherever these endothelial cells are present, they cause vasodilatation in brain, in coronaries, in retina, and everywhere. And then they have antioxidative action. Oxidation is damaging, so antioxidative effect. And then anti-proliferative. Anti-proliferative effect probably would translate into less fast progression of atherosclerosis. And then antiplatelet. This endothelium with the help of nitric oxide prevents platelet aggregation. All these things, all these good functions are performed by nitric oxide. And it has been noted that in almost all risk factors for ischemic heart disease, nitric oxide is reduced. In diabetes, in hypertension, in hyperlipidemia, and smoking. And people with diabetes, they tend to have all 3 or 4 conditions together. So all are responsible for reduction in nitric oxide. So this nebivolol can restore nitric oxide mechanism and probably can prevent some complication. So vasodilating beta blockers, better side effect profile because they lack beta 2 antagonism and they have this beta 3 agonist activity and alpha effect also. So better tolerability and better efficacy. But all vasodilating beta blockers are not the same. I'm going to compare nebivolol and carvedilol. Let's examine nebivolol versus carvedilol. As I said, all vasodilating beta blockers are not equivalent and both are vasodilating beta blockers, but let's examine the differences. When it comes to beta 1 selectivity, nebivolol is 320 times more selective for beta 1 as compared to 1 to 1. So carvedilol is not beta 1 selective. But this nebivolol has got beta 3 agonist activity and alpha blocking activity. And carvedilol also has alpha blocking activity plus this muscarinic receptor blocking activity. So improvement in ejection fraction with nebivolol, yes, with carvedilol, no. Direct nitric oxide production, yes, with nebivolol, no with carvedilol. Disturbed lipid profile, no with nebivolol, yes with carvedilol. Disturbed glucose profile, no with nebivolol, yes with carvedilol. And bronchospasm, no with nebivolol and yes with carvedilol. You know, this cardio selectivity is relative. Once you use very high dose, then cardio selectivity is lost, right? So these features are present only when we use nebivolol in like up to maybe 20 milligram. Once we go beyond that, then this selectivity may be lost and you may not then get all these unique benefits. Now let's examine that A, B, C, D again. So nebivolol has, for example, if you examine this, if you compare nebivolol with bisoprolol and metoprolol, you see that the selectivity, the beta 1 selectivity is highest with nebivolol. And when you see the mean flow, you can see that after using nebivolol, there is improvement in circulation. Whereas with bisoprolol, there may be some reduction. May not be significant, but certainly there is no increase. There may be some reduction in circulation. So because of this vasodilator action, there is increased blood flow. And then if we compare the effect on insulin resistance, you see this one, after use of atenolol, there is increased insulin resistance. And after use of nebivolol, there is reduction in insulin resistance, right? Very useful. Similarly, after use of atenolol, blood glucose level rises. And after the use of nebivolol, blood glucose level reduces. Of course, this is not strong enough effect to be used as a primary glucose lowering therapy, but at least this is a beta blocker which does not cause hyperglycemia, unlike traditional beta blockers. One very important side effect of beta blocker, the traditional beta blocker, is on the sexual function. Very, very important for men. Now let me give you the comparison of nebivolol 5 mg with metoprolol 95 mg. So when we examine erectile function, there is improvement with nebivolol. Not it is just neutral, it actually gives you some improvement, but the incidence of erectile dysfunction is significantly worse. The erectile function goes down with metoprolol. Orgasmic function, improvement with nebivolol, worsening with metoprolol. Sexual desire, improvement with nebivolol, worsening with metoprolol. intercourse satisfaction, improvement with Nebivolol more than the metoprolol. And then overall satisfaction much better with Nebivolol as compared to metoprolol. So I think Nebivolol performed better when we examine it for sexual function in a diabetic patient. This is the ABCD of type 2 diabetes. Now you see this is, and we will focus on this. If somebody has hypertension, diabetes and hypertension, you have used ACE inhibitors and ARBs, and there is compelling indication for beta blockers, and I suggest that you should consider Nebivolol, because Nebivolol has got all the benefits of beta blocker plus additional factors. It does not disturb diabetes and does not cause dyslipidemia, and does not reduce, it does not make heart failure worse. It actually leads to improvement, and it does not cause sexual dysfunction. So the clinical use indications are hypertension, ischemic heart disease, and heart failure with or without diabetes. We are discussing in the context of diabetes. So in diabetic patient, if there is ischemic heart disease or heart failure, maybe I think you should use Nebivolol in combination with ACE inhibitors. Then dosage 5 milligram to 20 milligram with or without meal. Now this drug actually is metabolized by the liver using this cytochrome system CYP2D6, and there is genetic polymorphism. You know, people could be slow metabolizer or fast metabolizer. There is no simple way of telling. So those who are slow metabolizer, they are likely to have much more effect of the same dose, and the duration of action is also likely to be much more. Since there is no way to tell, I think the best policy is to start with a low dose. For hypertension, 5 milligram, and for heart failure, 2.5 milligram, or even half of 2.5 milligram. So in heart failure, you start with a low dose just to make sure that if somebody is slow metabolizer, that patient does not get excessive effect of beta blocker. Then there is a possibility of drug-drug interaction, because there are other drugs, some antipsychotic drug, some antidepressant drug, some other drugs, they also are metabolized through this channel. Now, if patient is taking those drugs, there may be drug-drug interaction. So it is best if whenever you price Nebivolol, you just go through the list of possible interaction and then make adjustment in the dosage accordingly. Beta 1 selectivity is dose dependent. If you exceed certain dose bracket, then beta 1 selectivity is lost. Then those complications which are attributed to beta 2 effect, they can also be seen with Nebivolol. Then unique nitric oxide effect is very, very beneficial. So I think this makes this beta blocker a very, very unique. So the summary is, use beta blockers in diabetic individuals as indicated, and indications are hypertension, ischemic heart disease, and heart failure. And don't be afraid of this dark side, as Nebivolol stands out as a preferred agent as it has got no darker side. So I just hope that I've made a case for usage of beta blocker in diabetes, particularly this new vasodilating beta blocker, which is cardioselective and has got additional nitric oxide production, nitric oxide promoting effect. So with that, I think I like to conclude. This has been Professor Aziz-ur-Rehman from Medurstand. I really look forward to see you in my next video. Thank you.